Thanks, Salome, for the invite to this incredible conference. Amazing lineup, great opportunity to connect with others in the digital behavioral health space. And, well, if you know Salome, you shouldn't be surprised that she basically pulled together what could easily be the best digital behavioral health conference I've ever attended in a few weeks. I'm Omar Manejwala. I'm a psychiatrist and I'm the chief medical officer of Dario Health. We make behavior change in chronic disease the path of least resistance. In other words, our focus is on using digital and hybrid approaches to make the right thing to do the easy thing to do. So you're hearing a lot in this conference about COVID and post-COVID mental health, and that's the coming crisis. I'm sure Patrick Kennedy and Tom Insel will cover both those areas masterfully. You think about economic insecurity, fear, physical distancing that's led to unfortunate social distancing, loneliness, all the factors that drive a worsening of mental illness. Just as we had leveled off deaths of despair in the U.S., now we're going to see increases. And in particular, my heart goes out to those folks for whom home is just not safe. People with domestic violence, intimate partner violence, child abuse, substance use disorders in the home, trauma. Home is actually the least safe place for many women in America. And so if that's you or if it's someone you love, I want you to know you're not alone. We're with you, and we hope you get the help you need. And so we need to address that even more urgently now. Add to that the fact that we know that ACE scores and early childhood trauma lead to mental illness, and we expect more of that kind of trauma in this environment. So we aren't talking about a year or two of negative outcomes from this, but we may be dealing with decades of impact. Contrary to what many of the experts are saying, this is likely to be quite persistent in terms of its effects. In fact, a recent study from the Robert Wood Johnson Foundation estimates that we'll lose an additional 75,000 people to deaths of despair, suicide and SUD-related deaths, substance use disorder-related deaths, and due to economic despair. So all that's really terrible. And while in the U.S. we were way too late on testing, on tracing, and on taking this seriously. We were too late. There's still time for us to take the looming mental health crisis seriously. And yet, this acceleration of remote interactions has also had some positive impacts. In many ways, it's ripped the Band-Aid off the problem, exposing mental illness where it had previously lay hidden, and driving up help seeking among those who are suffering. And that's a good thing. And I would venture to say that most attendees here probably agree that opening the barn doors on digital health and on telehealth is a good thing. And we hope that now that the digital health bell is ringing, it can't be unrung. We hope it won't be unrung. And we're seeing some really good moves from the regulatory standpoint in terms of telehealth. We're starting to open the door in terms of remote patient monitoring and digital health. We're seeing some improvements in sensible approaches to benefit design. For example, waiving member cost sharing and other kinds of favorable improvements in benefit design. Everyone hopes that these are not temporary. Once we see the benefits, I'm confident they won't be temporary. And even in this environment of massive telehealth increases, and in fact, I saw a study that came out just last month that showed that the Blue Cross Blue Shield of Massachusetts telehealth claims had increased 3,600%. And all that's really good news. But even so, we do know that the majority of people with behavioral health issues are not seeking care. And so what's urgently needed, What's needed right now is scale. But everyone knows what happens if you magnify a problem. If you magnify a broken system, you magnify the problems in that system. So we need to be thoughtful about scale. And that's what I want to cover with you today. What we're getting right, what we're getting wrong, and what we need to do immediately to effectively scale behavioral health and help all those people who are suffering and for whom simply providing access is not going to be enough to improve their behavioral health condition. So we really have three types of key problems when it comes to scaling mental health in the United States. First and foremost, we do not have enough providers. We don't have enough providers, and we won't have enough providers. Even if we open the faucet all the way, all the telehealth in the world, and turn on all the providers and even increase the rate of training and certifying providers, we still can't cover the people who need help. We have, in the United States, we have about 30 psychologists per 100,000 people. We've got about 15 psychiatrists per 100,000 people. 15 psychiatrists per 100,000 people. There's no way that's adequate. We have 115 million Americans who are living in areas where there are provider shortages, which is defined as one professional for every 30,000 people. So telehealth can address some of the lumpy distribution, but it'll never solve the fundamental workforce inadequacy. The question is whether many or even most cases can be managed in some other way. PCPs, the primary care physicians, and collaborative care, which is an approach that empowers the primary care environment with expertise and support from specialists, and coaching rather than therapy for many, and really democratizing access to self-managed resources. And collaborative care is great. Collaborative care is very effective. But, even in fully deployed, even in academic environments, the majority of people who are exposed to collaborative care still don't really seek care for behavioral health conditions. So it's a big step forward, but it can't solve the problem. We have to think bigger. The answer might even involve over-the-counter antidepressants at some point and other agents. The reality is many of these are safer than Tylenol. I know that's a little blasphemous to say that, but I'm old enough to remember when Zantac was going to go over the counter, and the GI docs were terrified of losing their business. And what happened? The opposite happened. And so in general, people can be trusted. You give them the information, people can generally be trusted within limits. There's obviously a major and critical regulatory role, but the limits right now on many of these drugs are essentially discriminatory against people with behavioral health conditions. People with other chronic diseases have an array of over-the-counter options that can help them. So, I'm not paid by any pharmaceutical company, so I can say whatever I want here. But the reality is that the limits have been very draconian and healthcare paternalistic, and maybe it's time to take a look at that too. I don't think that's going to solve the whole problem, but we really need to come at this from a variety of angles in terms of, as I say, scale requires democratizing access to resources. Digital health really has to play a role because telehealth alone can't solve it. Let's face it, telehealth is mostly people talking on the phone. You might think from reading press releases and looking at websites that it's a highly digitally supported kind of tool with video and dashboards and all kinds of AI-driven insights. But the reality is the majority of telehealth delivered in America is basically a provider talking to a person on the phone, and that that's a good thing. But it's really underutilizing its potential, and it's another reason why that alone won't solve it. It's like the old trope that we only use whatever it is, X% of our brain. Well, we're using far less than 1% of the potential power of digital health. So telehealth's a great thing. We need a lot more of it, but that alone can't solve it. And people spend most of their day, it turns out people spend most of their day and all of their nights not going to telehealth visits. And so care where you actually are, where you live, where you work, where you live your life is about integrating support and care into your life experiences. And that's digital health, really. So that's how we'll make the right thing to do, the easy thing to do, how we'll make effective care, as we say at Dario, how we'll make effective care the path of least resistance. So we need to further expand access to peer support, coaching approaches, digital therapeutics, in order to solve this, because providers alone can't solve it. I mean, that's simple math. And so the second challenge to scale is that we're failing to truly integrate. Integration is a term that is used so widely, so loosely, that it's come to be almost meaningless. It lacks precision. Everyone says they're doing it. Almost nobody is actually doing it. In fact, integration as a concept has become so watered down that many people actually believe that the mere act of a psychiatrist talking to an internist on the phone is integration. And of course, that's a good thing, but that doesn't really constitute integrated care. Care is fragmented for many reasons, but our system is really training people to expect fragmentation. And as we've scaled our systems of care, we have scaled the problems, including fragmentation. I can't help you with that, Mr. Jones. You need to see Dr. X over there. Or you have two different benefits. You have two different formularies. You have two different sites of care, 4 different mobile applications that you need to log into. And I'm being generous here with the numbers. I mean, the fragmentation is really very serious. Imagine if every time you clicked on Facebook Marketplace, it sent you to a static printed newspaper classified ad section on another site. That's the kind of thing we're doing with behavioral health integration. If you're, not to pick on anybody, but if you're a Silicon Valley firm and you bought a behavioral health startup, that doesn't make you integrated. That it's a good thing that you're bringing that in, but it's if you partnered with a behavioral health telehealth firm and stuck them in your app, that doesn't make you integrated. If you scale that, you may get more people using that solution, but you also get larger problems which become more difficult to fix. So integration is really about a unified and perhaps the most important thing, personalized care journey. Users shouldn't even be aware. People shouldn't even be aware of a difference between behavioral health and physical health. That experience should be so seamless that people aren't even aware of the difference, any more than, say, the average person doesn't need to know the difference between a vascular surgeon and an interventional radiologist. So just as an example, the approach that we're taking at Dario is, you check a blood sugar, you check in on your mood, you log your meals, you log pro-social activities, you have passive gathering of mood antecedents, you receive a microdose of a digital intervention on mood. All behavior change is contextual, and it's not simple. And so all those things can be done together, generally in less than a minute or two, with effective tools, and immediately providing value to the people who are doing it. People do what they view as valuable to them. If you want to scale behavioral health, you have to deliver a service that people perceive in real time as valuable to them. Nobody should ever have to raise their hand and say, I'd like behavioral health, or push another button or do anything differently. It should be part of an integrated care journey that's personalized to them. And the reason that's important is that mental health is health. We created the differences. I mean, our system created those differences and that fragmentation. And the way I see the industry going, we're at risk of simply digitizing those differences. And that's akin to paving a cow path rather than really innovating to integrate. And the third area and the third final challenge third and final challenge really that we face to scale is cultural. And there's so many aspects to this. It's hard to know even where to begin. Racial disparities in access to care, racial disparities in the actual care received, racial and socioeconomic variations in trauma, in stigma, in shame, in discrimination, All these are longstanding problems. And with COVID having a disparate impact, because COVID is having a disparate impact on this, the problem is only going to get worse, and the gap is only going to get larger. We live in a society where celebrities can be praised for seeking mental health care, and that's a good thing. But neighbors are still shunned for receiving that care, where people still lose jobs and get incarcerated for having an illness, where all care, not just mental health care, but all care is worse if you have a mental health condition. Your outcomes for medical care are worse if you have a mental health condition, and the care you receive is worse. And where care for chronic conditions is episodic, short-lived, inadequate. But just as much of a cultural problem is how the healthcare system itself, and even, I'm sorry to say, even how digital health innovators are applying sometimes very paternalistic solutions to this. The quote-unquote, I know what you need to do, I've read the studies, I understand the science, let me see how I can force you to do it. And that idea, rather than seeking to understand the unique barriers and accelerants, what's attractive to people, that are personalized to each user. And those differences between people are non-trivial. I mean, they're very serious differences in terms of how people, what the barriers are, social and behavioral determinants of health and others, and what the accelerants are, what the things that people are actually willing to do that they don't have the opportunity to do, but they would do them if they had that opportunity, and understanding that. And that's the unique power, I think, that AI brings to this, which is member segmentation, personalization, personalizing care journeys. And that's why we have 1,000, well, I don't know if it's 1,000, it's probably more than 1,000 cognitive behavioral health apps, and almost nobody uses them. And I'm exaggerating, but basically there are so many digital solutions for behavioral health and so low access. It worked in a lab, so let's see how many people we can force through it is not a path to scale. And to solve that kind of systemic cultural arrogance, we're going to have to worship at the altar of this mantra. What matters to people is generally far more important than what's the matter with people. And at the end of that path, with AI-driven member segmentation, with personalization, with sensitivities to social and behavioral determinants of health, with attention to people's preferences, their barriers, and their accelerants to change, at the end of that path lies engagement. The primary barrier to engagement is cultural. So, most people who need help aren't getting help. Post-COVID, the crisis is going to get worse. The impact will be felt for much longer than a year or two, especially with trauma. Providers alone cannot solve this, and neither can telehealth, although telehealth is a critical ingredient here. To get there, to get to scale, we're going to need to expand access to digital therapeutics and remote solutions. We're going to have to expand services to include coaches and peers, not just psychiatrists and psychologists. And finally smash once and for all the distinctions between mental and medical illness and treatment. And perhaps most importantly, we're going to have to eliminate the paternalistic and arrogant stance that we know what's best, people should do what we tell them to do. We know what people need. So there is hope. There is hope, and scale is entirely possible. Digital health actually makes all of this possible if we make the right choices right now. Thank you.